Hi everyone, and welcome to ABC's of Anaesthesia. And again, there's another special episode because I'm doing a viva here for podcast and the YouTube channel with Shehan. So welcome, Shehan. Thanks very much for coming along and getting examined. How are you feeling?
Thanks, Larry. Thanks for having me. Feeling like I'm getting there. Some good days and bad days, but hopefully not long to go.
Yeah, that's what. Yeah. It's only a few weeks to go now, isn't it?
Yeah, like 3 weeks or maybe less.
Yeah, okay. Hey, so how's your exam prep been?
I'm getting vivas quite regularly, and after attending your boot camp, I've done some changes to my technique, which I think helped quite a lot.
Oh, excellent.
So I think each viva I'm trying to improve sort of the technical aspect of things. That's what my focus is on.
Yeah, excellent. Is there any, I used to ask, we used to do this kind of performance tip thing in our part one podcast. Is there anything that you think really helped you with your study or, for this exam in general?
In general, I think like having the sort of homework done in terms of theory earlier for the written, and then now I don't have to sort of focus a lot about studying and I can focus more about like technique. That helped.
Yeah.
In terms of resources, I found your bootcamp was very, very good, and
thanks.
I'm glad that I got to do it early rather than late, so I sort of got a hang of things as to how I could sort of build up. And there were a few other sort of resources, but mostly it's just the feedback I get on each viva that helps.
Yeah, no, fair enough. Hey, so why don't we get started? So again, what I'm going to do, I'll present a scenario. I'll just put it into the chat for you, but then I'll mention it as well on the screen for YouTube. So there's this clinical situation, and the question is, how would you further assess this patient? I'll just put that there. So take 2 minutes, and at the end of 2 minutes, I might actually ask you what stuff you wrote down. So for the audience, it's a 68-year-old male who presents to pre-admission clinic in preparation for a right upper lobe lobectomy for primary lung carcinoma. His surgery date is 2 weeks from today. Now, his past history is notable for being an ex-smoker, 50 years PAC history, COPD, hypertension, ischemic heart disease. So he's had some intervention, like a stent placed in the left circumflex back in, let's say, 6 years ago, and also hypercholesterolemia. So how would you assess this patient is the question. So take 2 minutes and we'll chat about what you've written down in a couple of minutes. Okay, Shehan, what did you write down in that 2 minutes?
So I have a gentleman presenting for a high-risk procedure, and he's got multiple significant comorbidities. In my assessment, I would base on history, examination, and investigations. With regards to his respiratory function, I would see what his respiratory status is, whether he's got any oxygen requirement and whether he's on oxygen at home. With regards to his COPD, whether he's had any previous ICU admissions, any bullae in his lungs, and whether he's got any follow-up established with a respiratory physician, and whether he's got any features of copulmonale. With regard to his cardiac issues, I would assess he's got any features of left and or right heart failure, including his NYHA class, and whether he's on any anticoagulation for following his stents. With regard to his medications, I would assess his bronchodilators and other puffers if he's on, his antiplatelets and other medications, which needs to be optimized. With regards to his malignancy, I would assess what sort of grade the malignancy is, whether there's any evidence of metastasis. In my examination, I would focus on his vitals, including saturations on RUMIA, blood pressure and heart rate, and his weight. And I would further proceed to investigations, including basic blood tests, coagulation profile, lung function tests, and a transthoracic echo if he hasn't had one recently.
So you mentioned a few things that you wanted to get. Did you want to know about the exercise tolerance of this patient?
Yes. So with regards to both his cardiorespiratory issues, I would focus on his exercise tolerance, assess his, like I said, his NYHA sort of class of symptoms if he's got any heart failure. So that would be a main focus of my assessment.
Sounds good. Any other blood tests besides the ones you mentioned?
So I mentioned full blood count, EUCs, and quags. I would make sure that he's got a group and hold and a cross match ready as well.
Excellent.
Yeah.
Anything? You mentioned a few things with assessing of the cancer. Just mention those things again.
So what sort of stage cancer it is, what treatment he's received so far, and whether the intention is curative or palliative would be the main.
Yeah, sounds good. Now I'm just going to show you some lung function tests. Let's see, I'll just share the screen.
He's got FVC of 76%, which is normal. However, his FEV1 is quite low, and if his FEV1 FVC ratio is significantly low as well. So he's got severe, moderate to severe obstructive lung disease. And he's got a low carbon monoxide diffusion capacity, indicating a diffusion limitation as well.
Anything else you want to comment on?
He hasn't got much bronchodilator responsiveness.
Yeah, great. What does that tell you?
Which is in favor of COPD rather than asthma.
Yeah, fantastic. Yeah, good. So so that was a good assessment. So, first of all, you've outlined your framework, history, examination, investigation. And I like that you just went through the usual things and you made some predictions as well. So, we hear a lot of this word. I remember back when I was studying for this exam, one of the examiners loved asking about, the assessment would be essentially assessing the severity and stability of the disease processes involved or the diagnosis involved. And you were saying things like, COPD, are they on home oxygen? What are their vital signs? Have they been admitted to ICU or hospitalizations? And so I felt like you were giving me an indication of that you wanted to know how severe each of these conditions were, and you were going through them systematically. You also made some predictions, and I really like that. So, I asked about medications, but you didn't just say medications. You said, I would want to know about the puffer use and any antiplatelet medications, which would be the most relevant for this surgery. What's another thing you might expect a severe COPD patient to be on that might be pertinent?
Home oxygen.
Yep, absolutely. Anything else, medication-wise?
From medication's point of view, so they could be on oral steroids.
Absolutely. So that
which might need stress dosing if needed.
Yeah, absolutely. Good. Now, the one thing I think about, when you do this assessment, what is this whole assessment in the thoracic anesthesia context heading you towards?
I think the assessment is focused on the respiratory function, and and it would lead to trying to guess what sort of respiratory issues this patient's gonna get in the perioperative period.
Yes.
I think that's the main focus.
And why is that? This sounds like an obvious question, but why in this case is post-op respiratory issues such a big deal?
So this patient might end up in an intensive care unit intubated post-operatively in the sort of worst case scenario. So that should be addressed prior to going ahead with the surgery, especially given that he's got a lung cancer.
Yep,
and
right.
Whether he's a candidate for that, and that sort of discussion should be had with the patient prior to proceeding.
Great. Do you know any models of prediction of, this patient having a problematic post-operative dyspnea or needing ventilation post-operatively?
So this patient will require one lung ventilation. So there aren't many established models for one lung ventilation. However, for single lung, two lung ventilation, there are predictive values, including Lumen oxygenation.
Not worrying about one lung ventilation. Do you know any kind of prediction or flow charts by the thoracic societies about post-operative dyspnea prediction?
I'm not aware of that.
That's all right. So as part of your pre-anesthetic assessment, you want to determine the predicted post-operative FEV1 and the predicted post-operative DLCO, abbreviated as PPO FEV1 and PPO DLCO. What are these and how would you measure them?
Predicted FEV1 would be the forced expiratory volume in the first second. So you would use a spirometry to measure that.
Yep. And so you've already got a value for that. So let's say your FEV1 over FVC is 45%. What's your predicted post-operative value? How do you calculate that?
It will be much lower than that level, but I'm not sure of any formula that to calculate it.
Okay, good. So this is one of those, once you know it, okay? So predicted post-operative is your preoperative value multiplied by the remainder of the lung that exists. So if you imagine you've got, the full lung is 19 segments. If you take away the right upper lobe, that's got 3 segments, you only have 16 segments left. So now you've got a fraction. So your PPO FEV1 is 16 over 19 multiplied by your pre-op value, if that makes sense.
Right. Okay.
Yeah. So when you hear that PPO DLCO, PPO FEV1, that's the kind of value you're looking at. So it's not that much less. So say it's 40 something percent. We have here 43% for DLCO, 45% for FEV1. If you take 16 over 19 multiplied by that, you roughly get around 36% is your PPO FEV1 and PPO DLCO. Now, based on these lung function tests, is there anything else you need to know to predict how high risk this patient is of post-operative dyspnea?
His room air oxygen saturations and partial pressure of oxygen on room air.
That might be. Yep. Keep going. Anything else?
In terms of his rest of the lung, whether there's any rest of the lung is diseased, whether there's any history of like pneumonia or any scarring involved in the rest of the lung.
Yep.
And from a symptomatic or functional point of view, what his respiratory symptoms are. And I think other important thing is if he's got a history of copulmonale and pulmonary hypertension, which would also indicate degree of dyspnea post-operatively.
Okay. Hey, I'm going to show you these flow charts. Have you seen these flow charts before?
No, I'm not familiar with this one.
That's right. So this is, I'm sure there's many different kind of risk stratification indices out there. I think it's important to have one of them in mind. So one of these is the British and one of these is the American Thoracic Society guidelines. This may have been, this may have been modified or improved from since when this was, but essentially my risk assessment for post-operative dyspnea, you'd pretty much have a spirometry and DLCO for everyone. So if according to this guideline, if their PPO is greater than 40%, then it's low risk. So this one's less than 40%, which goes onto this chart here. And so then I always need some kind of functional test. So if the shuttle walk or 6-minute walk test, if that is good, then no need for cardiopulmonary exercise testing. Then you'd say that they're straight to moderate risk. But if the function was really poor, you'd do CPAP. And then if you get VO2 max less than 15, then you go to high risk as well. So personally, I'll just memorize one of these charts, just understand that you need spirometry, maybe functional testing, maybe CPX or CPET testing. And that way you can stratify the risk of each of these.
Right.
Yeah, good.
And this is purely for respiratory.
This is very specific.
Disease or
lung resections.
Lung resection. Okay. Yeah,
good. So when I asked that question about your assessment, I think your assessment was really good because you're tackling a lot of the high points. You're getting through a lot of the commentary of what you want. But then the next step would be to go, look, I am likely we're going to resect the lung. This patient is at risk of post-operative dyspnea or ventilation ICU. How would I do that? I'd use a functional test. I'll use CPEX. I'll use spirometry. So in the assessment, you're already thinking about that. So now and that's where you want to go with this. So let's keep going. What options do you have for the Airway for this let's say it's just a thoracotomy, not a video assisted, but just thoracotomy?
So the main options are using a double lumen tube or using a single lumen tube with a bronchial blocker. Would be my two main options.
Any other options?
In an emergency scenario, I would use a single lumen tube in endobronchially, but I wouldn't use that in an elective scenario.
So your preference is double lumen tube for this?
Yes.
Yeah, great. You choose a double lumen tube. How do you size it for this man?
So based on his height, so do I have a height for this
let's
patient?
say this patient is 170 centimeters and 80 kilos.
For a 170 centimeter male, I would use a size 39 double lumen tube.
Mm-hmm. How tall? Sorry, for 100.
So for a male patient,
yes.
Between 160 to 170 centimeters,
yep.
I would use a size 39 tube.
Yep.
If they're more than 170 centimeters, I would use a 41 tube.
Excellent. I agree with you there. Would you use a left or right? It's the right thoracotomy.
So this is a right upper lobectomy, so I would use a left double lumen tube.
Excellent. Now, let's say we're doing a left-sided thoracotomy. What are the advantages? Like, would you still use a left, or would you use a right for a left-sided thoracotomy?
I would still use a left-sided double lumen tube, but it also depends on which level the thoracotomy involves. If it involves a main bronchus, and in which case I would have to use a right-sided double lumen tube.
What are the problems?
But the left-sided double lumen.
What are the problems?
What are the problems with
a right-sided double lumen?
Right-sided. So it's technically quite hard to place because the right upper lobe bronchus has a quite acute angle. So you need to place the Murphy's eye right at the division of the bronchus. And it's more prone to disposition, displacement, especially when you break the table to gain access for the thoracotomy.
That's good. So I agree with you that the right upper lobe turnoff, that is the problem. But I reckon it's because of the distance rather than the acuteness of the turnoff. So I don't care too much about the acuteness, but how far is that turnoff from the main bronchus?
It's very short. It's very soon after the main bronchus, the right upper lobe bronchiole takes off. So it's a very short distance.
Roughly how much do you reckon?
About 1 centimeter.
I've got around 2.5 centimeters.
Okay.
But yeah, it's short. How about the left upper lobe? Where's that? How far is that turn off?
It's much longer than that. I'm not exactly sure how far, but I believe it's around 3-4 centimeters.
Yeah, sounds good. Yeah, I've got about 5 centimeters here. Okay. Now, what are the advantages of the double lumen tube and what are the disadvantages?
So the advantages of double lumen tube are they provide reliable sort of lung isolation, and you can use it to prevent lung contamination, especially if there's suppurative disease. And also it's less prone to malposition compared to bronchial blockers, and technically much easier to advance or insert. Disadvantages include they carry a higher risk of barotrauma and mucosal trauma. And they can cause intraoperative hypoxia, which can be difficult to treat, especially with lung isolation.
What would you say?
The other disadvantages are, sorry, what is the line?
Oh, that's right. There's a delay on the thing. Why would you say it's more difficult to treat hypoxemia with a double lumen tube versus a bronchial blocker?
What difficulty?
Yeah, why would you say it's more difficult to treat hypoxemia with a double lumen tube?
With a double lumen tube compared to bronchial blocker?
My thoughts are because you've got ability to ventilate each lung independently, you might have an easier time with ventilation, and you can apply CPAP to the independent lung or the operative lung. But no, that was good. Yeah. So I agree. It's the gold standard for lung isolation. You can get rapid inflation or deflation of either lung. So I find that's really useful. You can also suction, use a fiber optic down either lumen as well. each one can be ventilated separately. CPAP can be applied. So obviously a lot of really good advantages. And yeah, I agree. I've placed a few bronchial blockers, and it's easy enough to do, but it feels far more easy to displace, and it's just a lot trickier. Have you done many bronchial blockers?
Not many. I've done one or two.
Oh yeah. Which one have you used? Do you remember the name of it?
The Cohen one, the one with the loop.
Oh yeah. And there's the
sorry, Aunt.
Yeah, I found the Cohen one's easier because you just have to rotate, whereas you don't have to worry about the loop. But yeah, I agree. It's more difficult to insert. The double inch is bulky, causes trauma, maybe very difficult in a difficult airway. And also, yeah, in younger children, in the pediatric cases, it's just not possible. So just describe for me, how do you place a double lumen tube if you were to step me through the process?
Preparation is as per standard intubation. On top of that, for the double lumen tube, I would preferably use a video laryngoscope, which allows better visualization. And I would apply good lubrication and a stylet. Once the bronchial cuff is through the vocal cords, I would rotate the tube 90 degrees anti-clockwise, and then proceed the tube until I feel resistance. Before proceeding, I would make sure I take the stylet off. Then after that, I would proceed to making sure the placement is correct. So initially by looking at the EtCO2 trace, I would then inflate the tracheal cuff and then listen for bilateral air entry. And then I would clamp the tracheal limb and inflate the bronchial cuff and ventilate through it, and then look for unilateral air entry. And then I would reattach.
I just want to clarify, as you inflate the bronchial cuff, do you have a method of inflating it?
So I usually add 1 to 3 mils, or as per manufacturer's guidelines.
Yep.
And then I would check the pressures.
Good. I'm glad you said check the pressure. So, I'd always use a manometer for these cases. But what the system that I've been taught and, that we do at our hospital is I'm glad you said you inflate the tracheal cuff, you get ventilation, you've checked all of that. So you got a position of safety. I then clamp the tracheal lumen. As you said, I open the tracheal lumen. So now I can have a leak. I gradually give 0.5 mils into the bronchial cuff, 4.5 mils at a time until I hear no leak from that tracheal lumen. And that way I'm stepwise doing it. After you've done that, what else do you do?
So after I've confirmed the position, then I would do a bronchoscope through the tracheal lumen and then look for the blue bronchial cuff just in the left main bronchus, and make sure that it's not herniating into the trachea.
Fantastic. That's great. Just moving on now. What do you plan for analgesia for this patient post-operatively?
I would request surgeons to put in so I would use a multimodal analgesia for this patient. I would further assess, take a pain history and assess his pain. But as a general method, I would request the surgeons to insert a wound catheter for this patient. And on top of that, I would give this patient a fentanyl PCA. And regular paracetamol. I would probably avoid NSAIDs in this age group. If the surgeons are not happy to put in a wound catheter, then I would consider an erectus spinae catheter.
Yeah, sounds good. What kind of wound catheter did you mean? Where is the catheter that the surgeons would place?
So it's an intercostal nerve catheter.
Okay. We usually use an extrapleural catheter. Kind of covers a larger zone than the intercostal catheter, I'd say. But if that's what you guys use, that sounds reasonable. Would you ever use a paravertebral catheter for this if the surgeons weren't doing their thing?
So my first choice would be an erectus spinae catheter compared to a paravertebral catheter, because that's the technique that I'm more familiar with. And it's also shown to be non-inferior and less sort of neuraxial side effects.
Sounds good. Back when I was training, we didn't have erectus spinae catheters. No one had really done that technique, so it was always paravertebrals. But yeah, I accept that. That's good. Okay, good. Now, continuing on with the case, as you're doing the case, the surgeons are well into their dissection, and you notice that the oxygen saturations decrease down to say 88%. What do you do?
So this can be expected with the one lung ventilation. However, I'll be with an 88% of oxygen saturation, I'll be quite concerned. I would immediately attend to the patient, scan the monitor, alert the surgeons that the sats have dropped, get my anesthetic assistant to help me as well. My first priority is to improve the oxygenation, so I would increase the flows and increase the saturate of FiO to 100%. And then I would scan from the patient and back to the ventilator to look for any, to identify any cause. After these temporizing measures, I would perform a bronchoscope through the tracheal lumen. So differentials at this stage are displaced ET double lumen tube, atelectasis or a collapse of the lung causing hypoxia due to the VQ mismatch. Potential serious, less likely causes are pneumothorax, which I would like to exclude, or bronchospasm in a COPD patient.
Now, interestingly, you went straight to the bronchoscope. Why did you do that? Is there any other things you could do before you went to the bronchoscope?
So prior to that, I would listen to the lungs and listen for any bronchospasm and airway. Good.
Hey, so I actually really like your format there. I feel like you got through a lot of stuff pretty quickly. So you said, look, I'd scan the surgeon patient monitors. You're checking all the safety features. You want to prioritize oxygenation. Again, obviously a great thing to say. And you tell the surgeon what's happening. And you've noticed, you're getting all your assistance and your help. I like that your way was systematic. Oxygen up, flows up. And then it was curious that you went straight to a bronchoscope, because I think what you would actually do in practice is flip to the bag and ventilate by hand. And that would give you a lot of indication of compliance and what's going on. And I often auscultate straight away. Why would I really want to auscultate this patient aside from other thoracic patients?
So for this patient to listen for any bronchospasm, given that he's got COPD.
Excellent.
Also to listen for an air entry to look for a pneumothorax.
Yeah, good. So
again, is that a high risk of?
You're absolutely right. So in this patient, maybe they had bullous lung disease. Maybe I wasn't sure of it. Maybe I used high pressures because I'd set the ventilator wrong and I was ventilating one lung with super high volumes or high pressures or whatever it was. So yeah, I'd check all those things. Let's say you hear quite a bit of wheeze and you hear sputum. Actually, one more point. So I remember one of my bosses telling me back in the day, whenever you get hypoxemia in a case that's like one lung ventilation, this is all the causes of hypoxemia normally, and it's the one lung ventilation causes. So you don't forget your system. So that's why your system was good. Just add on those extra things. But I'm thinking about all of those causes as well. So let's say now you get you hear a lot of wheeze, you hear a lot of sputum sounds. So noisy lung, not noisy dependent lung. What do you do?
So I would again be quite concerned about this patient. I would commence on salbutamol metered dose inhaler through the circuit and give 12 puffs and continue to do that until I get an improvement. And also I would give some Atrovent 500 mics as well. I let the surgeons about this, and the next priority is to suction the sputum plugging.
Fantastic. So you do those steps, you manage to clear most of the secretions out. Now, and the wheeze sounds a lot better. So you've taken care of that problem. The sats are still pretty low. They say still hovering at, they fell to say 70%, but with your maneuvers, you've now brought it back up to say 89, 90%. But you're still a bit concerned for this patient. How else could you improve the oxygenation for one lung ventilation?
So in order to improve the oxygenation, my next step would be to increase the PEEP of the ventilated lung. So for that, I would optimize the PEEP to 5 to 10 centimeters of water, bearing in mind I don't want to cause any barotrauma to this patient. And the next step following that would be to apply CPAP to the non-ventilated lung. So for that, I would use a CPAP application device and then dial my CPAP until I get a reasonable response with the saturations.
And what is the device you could use for CPAP?
I don't know the exact name for it, but it's a device where you can change your CPAP settings that attaches
have a look at just so you see even your next thoracic case. Have a look at this. It's called it's just the trade name is Mallinckrodt. You know, that company Mallinckrodt, and it's like this little ventilating bag with a dial. So you turn it up to I think 5 liters per minute on the outlet, and you vary that dial depending on the pressure you want. But there's a thought that you could probably even use the Liddell bag with a PEEP valve. Just put oxygen in, have that attached to one of the lumens. I haven't done that before. Potentially could work. So yeah, that's right. You increase your FiO2, your flows. You've sorted out the other cause of hypoxemia. You applied PEEP to that lung, CPAP to the top lung. The surgeons don't want the CPAP to the top lung. It's affecting their surgical conditions. What else can you do?
The next step would be to clamp the upper lobe bronchial artery.
They're unhappy with that. They're not able to do that. What else?
So then the next step would be to resume intermittent two-lung ventilation.
Sounds good. So as it happens, it's a very difficult dissection. The cancer is quite extensive in the lobe. It's very, very hard to dissect. And they're not able to the surgeons aren't able to continue with the dissection with you constantly reinflating that lung. Are you okay with 90% in this patient? Or stats of 89, 90%?
Yes, especially given that he's a patient with COPD, and anyway, for these type of cases, I'm happy to accept a level of sats of 88 to 90%.
Yeah, sounds good. As you continue with the case, suddenly the surgeon looks pretty distressed. It looks like there's quite a bit of blood in the sucker. What's happening now is that the blood pressure is requiring far more aramine or miraminol. So supposedly now you're on 10 milligrams an hour of aramine, and the patient's gone from a heart rate of 80 to a heart rate of 110. What do you do?
So this is quite concerning, potentially a major bleed in the making. So I would call for help in this situation. As a temporizing measure, I would give them a bolus of crystalloids, 500 mils. And I would, in this, I would clarify with the surgeons what's exactly going on, what sort of vessel.
The surgeon's quite stressed. It looks, they've told you that they've nicked a vessel. There's quite a lot of blood loss occurring, and they're trying to get control of the situation.
So in this situation, I would activate the MTP. The priority is to get products as well as blood into this patient. Call for help and make sure that I've got 2 large bore cannulas. I've already got the arterial line. I would use that to use a blood gas as well. I would use 2 warming coils to give my products and warm the patient and optimize other adjuncts, including calcium, the pH, and the temperature, and I would make sure I give some TXA as well as other products and use my blood gases and coagulation assays. And if I have a rotum, I would use that to further guide my blood transfusion.
Anything else you want?
So in terms of access, so IV access, I would convert one of the peripheral lines into a rapid infuser line. If available, if cell salvage can be arranged in an urgency, I would have that arranged, but I don't think that would be possible in an urgent situation.
Let's say you're in a big hospital and they're able to give you the cell saver in 15 minutes. You're very fortunate.
Okay, so in that case, I would arrange that as well.
Anything else?
And then I would discuss with the surgeons whether to sort of in terms of surgical approach. So this is done thoracoscopically, or is it open?
Oh, no, open.
Yeah, so I would continue with product resuscitation.
That sounds good. Would you use get a level 1 as well?
Sorry, what was that?
Would you get a level 1 as well for your infusions? The rapid infusion?
Yes, I would. Yeah.
Okay, as the surgeons are dissecting, there's quite a torrential bleeding, and they ask you to drop the blood pressure because they need to be able to see the arteries and vessels to clamp it. What do you say?
In response to that, it depends on what my current hemodynamic status is. So I would allow some.
Let's say your blood pressure is running at 100, heart rate 120, and you're using about 10 milligrams an hour of aramine.
So in that case, I would allow some degree of hypotension as long as I'm happy that the end organ perfusion is maintained. So I would be looking at the ECG trace. Yeah. And I would further bring down the aramine infusion, but I would keep going with the blood products.
Okay. What blood pressure, what systolic blood pressure do you drop this patient to help the surgeons?
So this patient has a history of hypertension, so his baseline must be high. I would try to keep it within 20% of its baseline, but for a temporary period, as long as I don't see any ischemic changes, I'm happy with a blood pressure of around 90 systolic.
Okay, let's say the patient was hypertensive at 160, running 10 milligrams an hour of aramine, your blood pressure is 100, and the surgeons actually want the blood pressure lower, about 70 or 60 temporarily. What do you do?
For a temporary period of time, in order to improve bleeding control, to achieve hemostasis, I would allow blood pressure to drop for a very short period of time.
How does that feel? That feels uncomfortable, doesn't it?
It does, yeah. Quite uncomfortable.
This is one of those situations where, it obviously feels wrong to do it, but I think most of us would agree. And again, obviously ask a panel of your supervisors and your consultants what they would do in this situation, because I suspect that most of us, knowing that this is a bad situation, if the surgeon needs it for control, we would facilitate it. So I think you got to the right place. I often think you can, because this exam is also time limited, I feel that you could get to certain answers quicker. So, you might say, look, this is obviously not ideal for perfusion, but, for the surgeon to be able to control this bleeding, to remedy this situation, I'll be happy to temporarily drop this blood pressure. Obviously, looking at end organ perfusion, when we say the terms end organ perfusion, like what can you really tell? Like, blood pressure drops to 50. Yeah, not much. You're not going to see these ECG changes immediately. I mean, if you do, great, but I've never seen any really significant ST changes or anything. So we won't know until afterwards that there's been a problem, but we have to sort this problem out now. I like that you gave me a lot of information for that. So, you started by, getting help, rapid access, 2 IV access. You've already got the outline, you get products, you activate the mashless transfusion protocol, and you offered me aims. You're also keeping the patient warm, pH normal, calcium, and doing regular ABGs, Rotem, coags, because you really need to see how you're going. The one extra thing, as I mentioned, I'd ask for the cell, you never know, even in our hospital where cell saver is not on site, you can still get the staff in, the perfusionist and the cell saver person in half an hour, but you can collect the blood immediately. So there's always a way, even though it might not be on site. And I always mention the level 1 or rapid infusion device. Okay, that's good. Now, good. Let's say this patient, the blood pressure keeps dropping in spite of what you're giving. You're just not able to get enough products. The blood pressure now falls to 40. What do you do?
I'm very worried about this patient now. I would, if I don't have enough help, I would call a med call and get more people in.
Yep.
So the priority is to get in more products. Mm-hmm. I would insert a right IJ sheet to give the products much faster. Yep. And also look for other causes of his hypotension, potentially a tension pneumothorax or any sort of electrolyte abnormalities, so arrhythmias.
That's all good.
But my main concern.
You're still losing a lot of volume. Blood pressure's 30 on your outline. This
is rapidly escalating into an ALS scenario, so I would prepare for an ALS situation. I would have my team ready and allocated roles, have my adrenaline and defibrillator in the room on the patient, and then while I continue to resuscitate from volume point of view, I would prepare for ALS. In this situation, I realized the patient's on lateral position, so I would get the bed in and get ready to turn him over supine as well.
Okay, so let's say the patient is in the surgical position, which is left lateral. Your blood pressure is 30. The SATS trace isn't reading because the blood pressure is so low. You've got your end tidal is reading roughly 15 millimeters mercury, 15 to 20. Your heart rate is still sinus tachy at 150. You've given more and more aramine. Tell me exactly what you do now.
So this is quite a complicated situation because the surgeons need to get on top of the bleeding, but I need to commence CPR on this patient. Initially, I would start CPR on the lateral position and see if give the optimal sort of time for the surgeons to clamp a main blood vessel, such as a bronchial artery. But if they're unable to do that, I would have to get the patient supine and give them effective CPR.
Now, what's the cause of this arrest?
It's hypovolemic shock.
Yeah. What's the solution for the hypovolemic shock?
Stop the bleeding.
Yeah. So when you say do CPR and turn supine, does it feel a bit odd?
It does.
It does, doesn't it? Okay, so here's, yeah. I'm just putting it in because you're doing well. I'm just giving you this very tricky scenario, and what we're going to discuss here is going to be very contentious. So what are your thoughts? I've now mentioned the elephant in the room, that this is a horrible situation because the solution of ALS may impede the ultimate solution, stopping hypovolemic shock. What do you think? What are you going to do?
I think the ALS will not be effective if the patient continues to bleed. If the surgeons are able to put a clamp on a major vessel and temporize the bleeding, then I'm happy to turn the patient. But the priority here is to stop the bleeding. So if the surgeons haven't gained hemostasis, I would continue CPR on the lateral position.
Yeah. So I'm just going to tell you my thoughts. And again, this is opinion. This is a horrible situation. I've just got to give so many disclaimers and caveats because this is such a complicated situation that no one needs to do what we talk about right now. But the problem here is when we read the ALS guidelines, it says the patient is arrested, you don't feel a pulse, you start chest compressions, give adrenaline if it's PEA, and then continue 2 rounds, defib, etc. Now, I think that this is going to be one of the toughest situations because right now it's not ALS for everybody. It's a thing that's happening in theater. And so I would almost say that chest compressions that impede the surgeon is the wrong thing. And that's very controversial for me to say, but I would do exactly a lot of the things what you do. The solution here is the surgical clamping of vessels. So I'd have a very frank discussion and say, look, the patient's arrested. There's no output or minimal output. You need to do whatever it takes, whether it's increase the size of the cut, find that vessel and clamp it immediately. Otherwise, we're going to lose this patient. And I've had conversations like that, not in this situation, but where the surgeon's done something temporary. We've got back volume, like they've paused, clamped, got back volume, got back resuscitation, got back the blood pressure, and then have another go at it. So this is super difficult. I would hate to be in this particular situation, but I feel like this is a very nuanced case, and I'm throwing you in the deep end with this one. Just to say that, let's say you get this in the exam. I feel like this is one of the things where it might feel like the right thing to say in the exam, but it would be worthwhile going, this is really difficult because the ALS guidelines are for every situation, and this is very specific. I feel like chest compressions would impede in the solution. So I would have this discussion that we would put the defib pads on, shock the patient if they go into VF or VT, but we have to resuscitate, give adrenaline, but we wouldn't be able to do CPR or turn supine. We'd have to get the surgeon to fix this solution because chest compressions are not going to fix it. It's just going to push more blood out and keep the patient alive for another couple of minutes. What do you think of that? Does that sound reasonable?
No, I agree with you. I think it's going to be futile if the bleeding just continues to happen. It's just so hard to say that.
Exactly.
You wouldn't give chest compressions in an arrest.
Maybe the take-home message is, I definitely don't want to tell you what to do in this business. Look, I think this would be such a difficult situation, but I know that CPR for me doesn't make sense in this particular situation. So hopefully the language you want to use is things like that. I realize that ALS tells me to do this, but this is different.
Yeah.
Something different about this. My priority is this and this. This is what I think the best scenario is. But I understand that, it's not technically the flow chart. I think that's the right thing to say in this situation. Again, I'm not an examiner, I don't know, but I feel like this is one of those really tough situations. That's the end of the viva. Let's say the patients the surgeons get control of the lesion and everything goes well. How did you feel?
That was quite a tricky one. I think every time you get a thoracic case, it could go in many ways.
Absolutely.
So it was
I think you did really well. I feel like a lot of your frameworks are there. You've got, the structures at hand. Just the one piece of information about the flow chart for post-operative dyspnea prediction. Now you know that, great. That's what these exams are about. You learn things as people examine you. You learn the nuances. So maybe even look at the British Thoracic Society or the American Thoracic Society guidelines for this, for thoracotomies, and maybe they're the most updated things. And then finally, I think we just went through the options for the airway was good. Your sizing was good. Advantages, disadvantages, fantastic. Yeah, you had a good sense of the analgesics that would provide. And then I gave you a couple of different dilemmas. First, hypoxemia, which is normal hypoxemia and one lung ventilation hypoxemia. Always frame it in that and do all the usual things. You had a really succinct framework. I just added on, check the compliance, put the bag, auscultate the lungs. Great ways to sort out your problems. And finally, the one lung ventilation strategy. Oh, there's one other thing that Slinger's article, Slinger is one of those, he's done so many papers on thoracic anesthesia, and he talks about improving cardiac output as well. You really want to improve your VQ matching by making sure your cardiac output is good. So that's the one thing I would have added to that. Finally, arrest, we talked about it at length. That was a very tricky arrest. And this viva is never straightforward. The examiners always make it slightly off flow chart, slightly off whatever what you're normally trying to do. So I think thinking outside the box is one of the things that they really do test. But well done, Shehan. Thank you very much for letting us examine you live.
Thanks, Larry. That was a very good experience.
So thanks everyone, and especially thanks to Shehan for volunteering his time. Again, I'll post this on YouTube and podcast ABCs of Anesthesia. And hopefully this is useful. Please share with anyone who might be interested. See you next time.